Hello, everybody. Welcome to Global Response to COVID-19. This is webinar number 14. We have been here for 14 weeks discussing this topic. This meeting is supported by the Panamerican Trauma Society, the American Association for Surgery of Trauma, International Relations Committee, the World Coalition for Trauma Care, the University of Miami, and Virginia Commonwealth University, VCU. I'd like to say welcome to everybody. Everybody that is in this meeting agreed that the meeting is going to be recorded and is going to be published in the Panamerican Trauma Society website. I'd like to introduce Dr. Michel Aboutanos from VCU and ask him to welcome all the panelists.
Thank you, Dr. Marttos. Valeria, if you could show the list of the panelists, please. Okay, so it's really our pleasure for session 14 to present our panelists. We have Dr. Esteban Fuanini is joining us again. He has a pleasure for the Panamerican Trauma Society, Director of ATLS in Bolivia, Surgeon and General Director at Fuanini Hospital in Santa Cruz de la Sierra in Bolivia. We have Dr. Juan Carlos Salamea, Professor of Surgery and Trauma and Acute Care Surgeon at the Vicente Corral Moscoso Hospital, University of Azuay from Ecuador. We have Dr. Ruben Peralta, Professor, Senior Consultant, and the Director of the HMC Trauma and Critical Care Fellowship Program at Hamad General Hospital in Qatar. We have Dr. Lilian Abo, Professor of Infectious Disease at the University of Miami, Miller School of Medicine, and Chief of Infection Control and Antimicrobial Stewardship at Jackson Health System, Miami, Florida. We have Dr. Felipe Vega. Hopefully he will join us, President of the Panamerican Trauma Society and Trauma Surgeon in the Department of Surgery at Hospital Angeles Lomas in Mexico City in Mexico. We have hopefully Dr. Darren Scalea will join us as a PTS Executive Director, Professor of Surgery at the University of Maryland School of Medicine, and Physician-in-Chief of the Adam Cowley Shock Trauma Center in Baltimore, Maryland. And last but not least, Dr. Raul Coimbra. Needs no introduction. He's Executive Director of WCTC, Surgeon-in-Chief at Riverside University Health System Medical Center, and Professor of Surgery at Loma Linda University School of Medicine in California. So welcome all our panelists, and back to you, Antonio.
Thank you, Michael. Today's presenters are going to be Dr. Gustavo Marchain, Professor of Surgery and Chief of Surgery at the Sociedad at the Universidad Nacional de Asunción, UNA, School of Medicine, former President of the Sociedad Paraguaya de Trauma and Asuncion, Paraguay, Dr. Marta Quiodettis, Head of Trauma Unit at the Hospital Santo Tomás, Panama City, Panama, a very active member of the Panamerican Trauma Society, past Vice President, and also Dr. Rafael Barrera, Director of Surgical Intensive Care Unit at Northwell Health Long Island Youth Medical Center in New York, USA. I would like to ask Dr. Raul Coimbra, the Executive Director of the World Coalition for Trauma Care, to welcome all the associated societies that are joining us for the last 14 weeks.
Thank you, Antonio. So on behalf of the Pan American Trauma Society, the World Coalition, and WST, we welcome all the participants and all the societies that exist under the umbrella of the Pan American, the World Coalition, joining for 14 weeks this important webinar. I welcome all the participants from Latin America today that are in the audience. This is a pretty important webinar today, and I hope you take advantage of all the lessons learned here and the experience of the presenters. Thank you.
Thank you, Dr. Coimbra. So for the last 14 weeks, we initially focused in Europe, what was happening, and what the management in Europe helped us a lot to prepare this in Latin America and the United States to COVID. Then you have a huge surge in the United States. We focus a lot on what was happening. Dr. Barrera gave us a lot of report about New York. Then now you have a lot of problems in Latin America. And then looks like you're going to have a second wave in the United States after reopening. So today I want to focus a little bit in South America. And then I'm going to have Dr. Coimbra, Dr. Barrera, and Dr. Abu to start to talk a little bit about the second wave. And then next week, you're going to focus strongly about what's happening after reopening in the United States and have our friends from Europe to give their report about what's happening in Europe. So let's start today's presentation with Dr. Marchain from Paraguay. Dr. Marchain, welcome. Thanks for joining us today.
Sí, muchas gracias, doctor Martos. Realmente un alto honor poder compartir esta sesión con los amigos. Muchas gracias por la invitación.
All right, here you go.
Siguiente.
Yes, sir. Go ahead, please.
Go ahead, Dr. Marchain, please.
Sí, recalcar que no hay ningún tipo de conflicto de intereses y la charla la vamos a centrar en el análisis de tres factores importantes: el factor médico, el factor social y el factor económico.
So there's no conflict of interest, and we're going to focus on the medical, social, and economic factors of this disease.
Siguiente. Este es un cuadro que particularmente me gusta, que se llama pintura fotografiada. Es una fotografía y una pintura ensamblada en sí, y nos representa el papel entre el bien y el mal, entre la salud y la enfermedad, entre la vida y la muerte. Y es lo que ocurre actualmente en esta contingencia, en esta epidemia importante que golpea al mundo, que es el COVID-19.
So this is an image that he likes very much. It's a combination of a picture and a painting, and it talks about the difference between life and death, which is pertinent for this talk.
Bueno, esto es para presentar lo que está ocurriendo en el mundo. Esto es del 22 de mayo de este año, donde tenemos acá más de 5.127.000 enfermos. Hoy día ya ha sobrepasado los 8 millones de enfermos, y donde la mayor parte de los países en todos los continentes está siendo golpeado.
So this is an image of, we have more than 5 million people right now, and the disease has spread worldwide, and it's affecting every continent.
Y esto es para presentarle en ese coincidente con ese slide anterior. Al 22 de mayo, el Paraguay tenía 836 enfermos, de los cuales 11 fueron pacientes que fueron al óbito, 256 recuperados y 569 activos.
So the data from May 21st talked about 836 patients with the disease. 11 had passed away, and 256 had recovered, and 569 were active.
En esta época, en mayo, de más de 43.000 pruebas realizadas, se tuvo una positividad del 2.8%, siendo la edad promedio de nuestros pacientes de 29 años.
So out of 43,000 samples that were taken, the positive rate was 2.8%, and the average age was 29.
El primer caso lo hemos tenido el 7 de marzo, y ya el 10 de marzo el gobierno nacional ha declarado cuarentena total, es decir, primero el cierre de las fronteras, dos, la llegada de paraguayos desde el exterior ya en contingencia o albergues previstos para el mismo.
So the first case was March 7th, and they started with a strict quarantine on March 10th, I believe. And first thing they did was close down the frontiers, and then started returning Paraguayans abroad and set up places for them to quarantine on their arrival.
Se preconizó la cuarentena, entonces solamente el personal necesario podía salir de su casa, y eso se cumplió en forma estricta a nivel del gobierno. Se garantizaba la salud, se garantizaba la alimentación y los casos de necesidad imperiosa.
So there was a strict quarantine, which was regulated by the government. Only essential personnel were allowed to go out, and they did guarantee people access to healthcare and also to food supplies, and any people who were allowed out were due to extenuating circumstances.
Lo interesante de este análisis es que los dos primeros casos fueron médicos, y médicos muy cercanos. El primer paciente fue un médico que fue compañero de promoción de la Facultad de Ciencias Médicas, y el segundo paciente fue un paciente que fue mi jefe de neurocirugía en el hospital. Estuvimos trabajando en algún momento juntos.
So the two first cases were actually physicians. They were very close. Dr. Marchain mentions that the first one had been his classmate doing medical school, and the second person afflicted, a neurosurgeon who had been his chief during neurosurgical rotation, I presume, and also worked with him in the hospital.
Y el 70% de estos pacientes se ubicaba preferentemente en albergues, es decir, eran pacientes que cruzaban la frontera pero ya venían con la enfermedad.
So out of these numbers on May 21st, 70% of them are people, Paraguayans, who were returning to the country and had been confined in dormitories or residencies as they returned to the country and came back with the disease.
Siguiente slide, por favor. Bueno, esto es actualización al 11 de junio, pruebas realizadas más de 43.000 y las positivas 2.8, y la mayor parte de concentración de casos en el área de Asunción del departamento central, es decir, dentro de los 50 kilómetros al área de la capital, con el 30% aproximadamente.
So again, 43,000 cases, of which 2.85% were positive, and most of them were concentrated within Asuncion and in the neighboring region around 50 kilometers from the capital.
Y haciendo el análisis, el 70% aproximadamente del sexo masculino, y también un 60% de los pacientes eran pacientes que eran contenidos en los albergues.
So 70% were male patients and 60% were patients that were in the quarantine areas or the restricted housing for COVID patients.
Siguiente, por favor. Acá tenemos fundamentalmente los casos en el área de Asunción central y la periferia. Los casos más importantes se tuvo en los sitios donde hubo ingreso de paraguayos desde la frontera. Y en este momento, hasta junio, la cantidad de casos locales o sin nexo, como la llamamos acá, es una cifra cercana al 10%.
So as you can see, some cases were around Asuncion, but the majority were around areas of the borders and people who were returning to Paraguay. And about 10% of the cases are considered to be local transmission at this time.
Siguiente. Esto para valorar cómo está Paraguay con respecto a una de las grandes potencias que es Brasil por la cantidad de poblacional, ¿verdad? En Brasil tenemos en este momento más de cercano a 40.000 fallecidos, y ya está cercano a los 800.000 enfermos en este país.
So there's a comparison of Paraguay with one of its neighbors being Brazil, one of them, and you can see that the number of fatalities is close to 40,000, actually confirmed is close to 800,000 patients in that country.
En todo el país tenemos en este momento 11 pacientes internados, de los cuales 2 están en la unidad de cuidados intensivos.
So currently in Paraguay, they have 11 patients that are hospitalized and only 2 in intensive care unit.
Y en el lapso de un mes no hubo fallecidos, pero en las últimas 36 horas hemos tenido 2 casos de fallecimiento. Es decir, de 11 fallecidos en mayo, ahora hoy 17 de junio tenemos 13 casos fallecidos.
So on May 21st, 11 people had died, and as of today, there's 13 people who have died. 2 of them have died in the last 36 hours.
Siguiente, por favor. Este es el informe del Ministerio de Salud hasta el día de ayer. 1.303 casos confirmados, 592 casos activos. Tenemos un importante lote de pacientes recuperados cercano al 52%, y esta cifra que dice 12 hoy suma a 13.
So you can see that the majority of patients are recovered at this stage, 52%, and this number that says 12 fatalities is actually 13.
Se mantiene la tendencia, predominancia del sexo masculino cercano al 70%, y la edad de predilección inferior a los 40 años, igual que en el trauma. El 80% de nuestros enfermos tienen menos de 40 años, siendo la edad de predilección 29 años.
So as you can see, still about 70% patients are males, and the majority of patients are under the age of 40, stating that 70% are under 40 years old in their country. And it's very similar to the numbers for trauma.
Y también se mantiene la tendencia de los casos que se manejan en los albergues, en las fronteras, es decir, son paraguayos que vienen por vuelos humanitarios de diferentes partes del mundo. Entonces, estos casos quedan, se le hace la prueba del PCR y quedan en cuarentena en los albergues.
So you can see the majority of people are in these confinement areas or albergues, about 70% of them. So when these are people who are returning from abroad, from other countries, and when they arrive, they get an RT-PCR, and then they're confined for a period of time.
Sí. Siguiente, por favor. Bueno, haciendo el análisis de los factores, por supuesto que este es un problema nuevo. Uno se pregunta, ¿hay expertos? La respuesta es no, no hay nadie que pueda decir que sea experto en esta patología. El problema del diagnóstico, la mayor parte de los países de bajos ingresos o ingresos medios tiene limitación para la prueba de los test, y nosotros sabemos que el PCR tiene una especificidad del 70%, o sea que hay un 30% que no va a poder ser diagnosticado. En cuanto al tratamiento, también hay controversias importantes, se manejan diferentes protocolos, no hay un tratamiento específico como toda virosis, y hay grupos que están haciendo tratamientos tanto con cloroquina, hidroxicloroquina, otros con ivermectina y otros con suero de los pacientes recuperados.
So there's, adelante, Gustavo. Okay, so there are really no experts for this disease at this time, since it is a novel disease. There have been some issues with diagnosis, not only because of economic factors for a part of the population, but also because there's about a 30% false negative rate for RT-PCR in these patients. There's not a universal criteria for treatment, and a little surprising, but they're treating patients with ivermectin. Also, some people are treating them with hydroxychloroquine, and some people with convalescent plasma at this time. But there is no standard care in Paraguay.
Siguiente, por favor. Específicamente en Paraguay, los hospitales se están preparando. El problema principal que se tiene es la falta de equipos de protección. Hay una cobertura en este momento, ya que tenemos pocos casos, pero si hay un desborde, preocupa que el personal de salud, los médicos, las enfermeras puedan quedar sin equipo de protección.
So at this stage, there are limited cases, but there's a very large concern about the rise of cases in the country. And one of the main problems is the lack of PPEs. And the physicians and nurses have been quite anxious about the possibility of a surge and running out of supplies.
Perfecto. Dos de los grandes problemas que está enfrentando el personal de salud es la depresión, la ansiedad y los problemas mentales. Y estadísticas nos dan cercano entre un 60 a 80% de problemas médicos dentro de este factor del área de la salud.
So what we're seeing also is a high number of depression and anxiety. Roughly 60–80% of the personnel are suffering from stress-related issues or from depression associated with the disease.
Siguiente, por favor. Y por si fuese poco, tenemos problemas de interpretación de la Organización Mundial de la Salud. La Organización Mundial de Salud ha dado pautas y recomendaciones lastimosamente no tan acertadas. Yo recuerdo que cuando empezó el problema acá en Paraguay, en mi hospital, quitamos una resolución para que en el servicio de cirugía nadie circule sin mascarilla. Sin embargo, la recomendación de la OMS en ese momento era que no hacía falta el uso de máscaras.
So to add to the problem, we've been receiving conflicting messages from the World Health Organization. And just an example, at the beginning, they recommended not using masks within the hospital, and then they reverted or changed those decisions.
Y el doctor Rafael Bengoa, español, nos dice, no se trata de tener camas en la unidad de cuidado intensivo, sino de la necesidad mínima de llegar a utilizarlo.
And Dr. Rafael Bengoa, a physician from Spain, is saying that it's not an issue of having ICU beds, it's just trying to prevent people from needing them through primary care.
Y la famosa frase, yo solo sé que no sé nada, tal vez es aplicable a la Organización Mundial de la Salud.
So Socrates' phrase, I only know that I know nothing, should maybe be applied to the World Health Organization.
Siguiente. En cuanto al factor social, ustedes verán ahí como el personal de salud, con la ayuda de las fuerzas militares y fuerzas policiales en Paraguay, reseccionan a los pacientes, se hace una historia clínica cuidadosa, ya se le toma a todos estos paraguayos que cruzan la frontera o extranjeros que cruzan la frontera al Paraguay. La prueba del PCR es obligatoria y mientras esperan, el paciente queda en cuarentena. Queda mínimo 2 semanas de observación.
So you can see from these images that at the frontiers, the military personnel with healthcare providers are receiving either Paraguayans who are returning to the country or foreigners who are entering, and everybody gets an RT-PCR and then is quarantined for a minimum of 2 weeks.
Y sí, y así como se habla de los millennials, también podemos decir que esta es la época de los pandemials.
So as we speak of the millennials, we can now talk about the pandemials, I guess.
Siguiente, por favor. El otro problema importante que tenemos es la repercusión económica. Y el Paraguay, a nivel país, por disposición de decreto presidencial, se ha destinado 1.600 millones de dólares para tratar de ayudar a contener a la sociedad.
So to try to assist, the government has destined $1,600 million to help the population.
Y en este momento, hoy 17 de junio, solamente un 4% ha sido destinado al área de salud. Es algo que es muy llamativo para las personas que están en cualquiera de los ámbitos.
And it's curious to see that only 4% of this money has been destined or has been given directly to providing healthcare in the country.
Y lastimosamente muchas licitaciones a nivel del Ministerio de Salud no han podido ser finalizadas. Hubo hechos irregulares que están en investigación, tanto a nivel de Fiscalía General o un equipo que ha sido nombrado por el presidente de la República y se asocia a hechos de corrupción.
So there's currently several cases that are being investigated right now by the presidency and the Attorney General associated or linked with corruption within the government regarding these funds.
Y como en toda crisis es una oportunidad, ¿verdad? Entonces, cuando uno está con problemas, hay que buscar la solución.
So like any crisis, you have to try to look for the solution to the problems.
Siguiente, por favor. Bueno, lastimosamente esta enfermedad no tiene en cuenta ningún tipo de edad, sexo, nivel socioeconómico. Y en Paraguay el primer caso de fallecido fue este médico neurocirujano, el jefe de neurocirugía de mi guardia en el hospital de trauma, y donde aparentemente él habría utilizado un consultorio donde previamente había sido recepcionado y valorado un paciente de COVID, y hay comentarios de que la transmisión fue hecha por utilizar el mismo ordenador, la misma computadora.
So unfortunately, this disease does not discriminate age or socioeconomic factors. The first fatality in Paraguay was the chief of neurosurgery at the hospital where Dr. Marchain works, and the presumption is that he was infected when he went into an office space that had been used previous to evaluate a patient with COVID. And when he used the keyboard on the computer, he may have gotten his infection at that point.
Y quisiera hacer una recordación también a una persona muy allegada al Paraguay, muy conocido por todos, que el doctor Alberto Basilio. Tuvimos oportunidad de trabajar por la Sociedad Panamericana de Trauma por muchos años, compartir muchas experiencias y lastimosamente hay amigos que nos están dejando.
And I also like to remember Dr. Alberto Basilio Olivares, very well-known trauma surgeon to everybody in this community and also in Paraguay, that he participated actively in several activities in Paraguay, and this disease is making us lose some dear friends.
Siguiente, por favor. Terminando, este es un cuadro que también me gusta mucho, que se llama Posible o Imposible. Es lo que nos plantea el COVID en este momento. ¿Qué hacer y cómo manejar en cada uno de nuestros países?
So there's another image that I like very much, which is called Possible or Not Possible. And it gives us a sense of what's occurring right now with COVID.
Siguiente, por favor. Muchas gracias y nuevamente mi agradecimiento al comité de organización de este evento.
Thank you very much, and again, my gratitude to the organizing committee.
Thank you very much, Dr. Marchain. Let's go straight to Dr. Marta Quiodettis from Panama. Dr. Quiodettis, when you have 1 minute to go, you're going to send a message, okay? Thank you very much for joining us today, and willing to hear your experience with COVID in Panama. Thank you.
Hello, I'm sorry, I'm having troubles with this computer again. So I'm talking today about Panama, and we have our first case 100 days ago. So these are the numbers. We are not doing so well. So we have a total population in Panama, 4 million people, barely. And remember that we are a very small country. And we have wonderful people, but a small population. And this is shared from the World Health Organization from yesterday. And it is, we are in the 11th position of more cases per million of inhabitants. So if you, in the region, in the American region, so if you see, we have a lot of patients and a lot of deaths. It's not the case like in Paraguay, as Dr. Marchain already presented. So yesterday, to 100 days after the start of this, we have a total cases of 22,000, barely to 22,000 cases, cumulative cases. And if you see the reported from the health minister in Panama, death cases is 457, and it's not the same as the one that are reported in the World Health Organization. I do not have an explanation for this, but of course it starts having some issues of credibility with the government and the reporting of the cases. The good things in Panama that we have at least until yesterday 93,646 tests done. Unfortunately, barely 30% of these cases are positive. So we have a lot of cases that we have been reporting, and it includes 0.05% of all the population in Panama is already tested positive. So the number of tests that we can perform so far has been 22,000 per million of inhabitants. And of those patients that we have in domiciliary confinement or quarantine, 6,325 people. There have been some hotels that have been arranged as shelters because a lot of people in Panama still live more than 6 persons in one house, and they do not have the arrangement inside the home to be isolated from other people. So this has been a problem with the community transmission that we already have. So from yesterday, we have 486 patients admitted into any hospital ward, and we have 107 patients in the ICU. That was from yesterday. So the number of patients according to the age has been the most are also between 20 and 60 years old, but the same behavior that the other places have been reported. Our mortality goes in those patients above 60 years old, and it's a high mortality rate in this population. And the other thing is that we have a lethality rate of 2.1% or 2.2, according, it depends on the source. And we kind of been doing well in that part, but I think it's not, those numbers are not acceptable for a country like ours. This is the distribution by age and the mortality numbers, as I previously mentioned. And the same behavior as other places. Men are more prone to get the infections. Women behave a little better, so we take care of everyone better. So that's why we do not get so many COVID cases. And this is the distribution of the lethality rate for the epidemiological weeks. We have not been above the 3% in all this time. As yesterday, we had it, before this week, we had a duplication rate of 20 days, it went down to 16 days, the duplication rate, and it is related to the opening of some economical activities that start on June 1st. And our time to replication or the rate of replication is 1.58. It was at the last weeks of May, it was in 1.01 or something like that. So we are behaving poorly now that we're starting doing some other academic, economic activities. And people are tired of being home. I don't know why, but they are tired of being home. And this is how we look from the space, I think, about our cases of COVID. The good news in Panama, we have the Gorgas Institute. They have been able to replicate the virus genome, and they have been seeing 4 different strains of the virus, and we got all these transmissions. It started probably from abroad, since Panama is always, or has been always been a bridge and a transport space. And we got cases from Europe, from North America, and China. How are we doing so far? I think we are getting worse, and the total amount of ICU beds in our country is only like 140. And places like the place where I was born in the WCTC, they have already not accepting more COVID cases because they do not have capacity. And we already in our hospital started ethics committee to start doing selection on who gets a ventilator or not. In trauma, COVID hasn't been able to stop the trauma. We are getting a lot of gunshot wounds patients, very bad traffic accidents patients, very young people too. And we start seeing patients that came asymptomatic and developed the disease while they were in the hospital. So now every patient that gets admitted to any surgical specialty in Hospital Santo Tomás, it gets a COVID test, a PCR test, and then if they are negative, they stay in the regular ward, and if they are not, they go to some area that is designated for COVID patients. About PPE, we are still not having troubles, but if this keeps on going up, we are going to get really bad, and we are not gonna get enough PPE for everyone who need it. And I just read this morning that our airport is not opening until July 23. So we are isolated, and we are keeping a quarantine that is not absolutely mandatory. And the women's goes out on Monday, Wednesday, and Fridays. Men's goes out on Tuesday, Thursdays, and Saturdays. On Sunday, nobody goes out except for essential personnel. And it hasn't been, all this measure hasn't been able to completely prevent us from getting this raise in the number of patients. And I think that this week or the next, we are gonna get overwhelmed in our capacities for taking care of these patients. So that's it for me.
Thank you very much, Dr. Quiodettis. We are almost 4 months after the first webinar, and you can see the problem shifting from Europe to the United States, now to South America. So this is a great problem. I'm going to discuss what's happening afterwards, please. And now let's go to Dr. Barrera. Dr. Barrera from Long Island. He did his first presentation when he was at the peak at his hospital. Then he showed a couple of weeks of improvement. Now we need to hear what's happening in Long Island. Dr. Barrera, thank you for joining us again.
Thank you. It's always a pleasure to talk to this group. As you well know, we're on Northwell. We have 25 hospitals. And this is a slide that I presented before. But basically, the epidemiology did not change. The majority of patients had comorbidities, either obesity, diabetes, hypertension, hyperlipidemia. In our case, the majority of patients were Black or Hispanics, and they were older. So that has not changed. At the end of the pandemic, which we consider now from Long Island Jewish perspective, we treated over 10,000 patients in Northwell. My hospital treated and released 3,000 patients. We discharged 1,900 patients that were hospitalized, 1,500 home, 400 to a facility, and at the end, we only did 20 trachs and pegs. This is the story of how we did if you notice, it's every Wednesday that I have presented to this group. So we started with only 700 patients in the hospital, 110 ventilators. Our worst day was between April 13, 22nd, which we had over 900 patients in the hospital positive with 152 ventilators. That day, we only had 17 ventilators left, but we planned to expand to 250 ICU beds. We had a total of 402 ventilated patients. And as of yesterday, we only had 4 ventilated patients and 32 patients on the floor. This is one thing that I think everybody should look at is the SCCM escalation in pandemic, how to do the critical care response teams. What we did is we had one intensivist or one team of 4 intensivists per teams to taking care of either 30 or 40 beds and with trained PAs or MPs and surgical trauma attendings and residents. So this is very important before the system collapses. This is our 60-bed ICU that was built. We expect 250 patients. We only went up to around 150, 170, and this is empty now. So we are ready for October, if that's one of the questions. For a second wave, we have the capacity right now of 100 ICU beds that are ready, and we can go at any moment. We have all PPEs, and this is an empty space right now consisting of exactly 62 beds with ventilators, monitors, and everything. As the treatment of this disease progressed, there were a lot of excess. We started with steroids, with azithromycin, hydroxychloroquine, then we did not do it. Now there's an article yesterday that maybe steroids might help. We have to look at the paper. It was only a press release. This evolved into this. This was how to treat from the ventilatory perspective. Consider steroids, maybe not, maybe yes. That's still up in the air, but there's a couple of things we did. So at the end, what we wound up doing is we followed the SCCM guidelines. And the only interesting thing here, the only difference is that we used a lot of high flow at the end, but the negative pressure ventilator rooms with high flow. The patients seem to respond to this treatment before intubation or they do better. So don't delay intubation, but at least try to use high flow if you can in a negative pressure room. And this is at the end of the epidemic. What we did, everything was protocolized and everything was a research project. So everybody was on remdesivir. We had the IL-1, IL-6 trial, the famotidine trial, and everything, but it was on trial on different arms for the patients. So everything, the most important thing I think is to protocolize care and have it in a very systematic way. Otherwise, everybody starts doing whatever they want to, because as you know, it's a novel disease, and nobody, as we heard before, there are no experts. Everybody needs DVT prophylaxis. I keep insisting on this, and don't be shy of starting either IV heparin or argatrovan. It seems that the patients that collapse with this disease do a lot better with argatrovan. So this is our protocol that everybody should be on DVT prophylaxis, on heparin or Lovenox, and following all the parameters, especially the D-dimers. And this is our, as of yesterday, we had no admissions and no deaths from COVID. So this is very good. We have all these protocols that we have developed, and this is one of the windows of the patients. We were so busy that we couldn't go to the EMR, so we had everything on the window, the most important thing, what the patients had, the pressors, the last ABG, and the ideal body weight to calculate things. And these are all the protocols that we came up with at the end of the 3 months of COVID. We have a protocol for everything. The most important thing, as we heard before, is a protocol of ethics and end-of-life discussions. That's very important, especially in a country that has limited resources. We did not have to utilize that much because we never had any problems with PPE, with ventilators, or medicine. As you've been preparing for this pandemic and you are in the emergency management response, you have to start thinking of how are you going to recover, especially the trauma surgeons, especially surgeries, and how you're going to recover the implementation of surgeries. We have right now 30,000 surgeries delayed secondary to the pandemic. You know, our system is very large, so we have to start planning. And I think I urge everybody, or most of the attendees are surgeons, how are we going to recover the surgeries with an ongoing operations for pandemic. And this slide, everybody saw, we hopefully will not be on this second wave. We're at the end of the first wave. Now the impact comes, what we're seeing now in Long Island Jewish in New York is all the delayed surgeries, we're operating a lot. We're operating during the weekends, during the nights to try to catch up. And all the chronic diseases now appear. Everybody that had a gallbladder, everybody had an appendix, everybody that had diabetes are starting here. And we have a very strong team effort for compassion fatigue, for stress of the nurses and PAs or MPs and doctors. So once a week, we are meeting for anybody that needs, we call it here Code Lavender. Everybody meets, everybody discusses. There's a lot of psychological help for everybody. And I leave you with this last slide. Just remember, this disease might not be all lung related. It might be hematological disease affecting thrombotic and thromboembolic disease. So please, to the colleagues that are starting the pandemic, good luck, plan well, and if you have anything, I'll be more than happy to help. We're, thank God, almost over with this. Thank you.
Thank you, Dr. Barrera. Great report and great to see your number changing, your hospital recovering. But I'm pretty sure that Dr. Lilian Abu, Dr. Raul Coimbra are going to comment in these on discussions because you are like this, very happy a few weeks ago, and now I'm really concerned what's happening here right now. So let's go quickly to the pool of questions. So we're going to have answer the 10 questions again, and then we're going to have solid 30 minutes for discussions. So Valeria, can you launch the questions, please? Okay, everybody read the question, you can answer. The first one is if your city or area is still having social distancing right now, or the reopening phase, okay? Second question, did your country or region had or is on lockdown? Third question is about what's happening in your region. So the number of cases are still increasing, not increasing, or plateau? Let's see what's happening right now in your region regarding the case. Question number 4. If your hospital or clinic or yourself are using protocols to treat COVID-19 patients, or is that discretion of the professional? Question number 5, is everybody of your emergency room or trauma wearing N95 masks while taking care of patients? Question number 6, what are the first medications given to any patient with diagnosed positive test that's sent home? Okay, patients have some symptoms, are positive, but they don't need to be in the hospital, sending home. So what kind of medication are giving to your patients? Okay, what are giving to your patients that are going home? Number 7, question number 7. What kind of medication are given to your patient that need to be admitted to the hospital, not in the ICU, but just admitted to the hospital? And then the question number 8, what kind of medication are given to your patients that are admitted to the intensive care unit? So once the patient is ICU, what kind of medication do you give? Okay, and the question number 9, what kind of medication or treatment do you think that you're giving is making the patient improve? Okay, number 9 and number 10, what kind of medication that you give to your patient you don't think that's making any difference on making your patient improve? Okay, so a few more questions for everybody to answer the questions. Okay, remember, once you finish, please press submit. So our question gonna be computed on the pool. Okay, so I'm pressing submit here. I'll press submit here again. So Dr. Aboutanos, please, could you quickly summarize the answers and then start with the question to the panelists, please?
Sure, Valeria can show the answers, please. Okay, so the first question, does your country area have social distancing practices in place? And you see that about 50% said yes, but more than 50%, less than 50% are respecting it. So even though they have it, it's really not being respected. That was for question number 1. Question number 2, does your country have lockdown procedures in place? And again, it's the same thing. You said almost about 40% saying yes, but 50% are not respecting it, which is interesting because you would think, I wonder if this is with regard to where you are in the phase at the beginning and the middle or at the end. It would be good to find that out in the questions and answer. Where does your area regional practice fall on the curve of daily COVID positive? So it is interesting, and I'm summarizing about 35%, most likely from the Latin American region, still increasing exponentially, while you see that in about 16%, if you add 32% to that, so almost another 40 to 50% say it's either not increasing, only slightly increasing, and I bet you depend on the region you come from. Number 4, do you have protocolized sequential treatment guidelines for COVID? And every time we ask this question, at least 60, 70% said yes. And I am hoping this conference is a major contributor to that. So that answer. Or number 5, are ER and trauma providers in your facility wearing N95 masks? About 40% says yes. And about 30% said most of them. And about only 3% said less than 50% of them. And again, it also depends whether those N95 masks are actually available in your country. So it's an interesting question. What are the first line medications started for any diagnosed cases of COVID-19 positive test and then sent home? and you will see about 45% saying paracetamol, and which as an additional 20% saying antibiotics, in addition to 16%, so almost about 40% azithromycin. You see with regard to hydrochloroquine, only 13%, and with regard to steroids, only 13% as well. Be interested to see if that will change now in light of the recent announcement that came out yesterday, which is making us, at least in our hospital, rethink it again. Number 7, what are the first-line medication treatments started early for COVID-19 patient admitted to the hospital? 40% in azithromycin, and interesting that 26% said saying steroids, and an additional 40%, almost 40%, prone positioning. And everybody, well, not everybody, at least 60% are using DVT prophylaxis. As we all noted, this is should be part of every protocolized aspect when it comes to COVID. This has not been challenged, but been actually enhanced and approved. What are the first-line medications? Excuse me. What are the first-line medications for severe cases of COVID-19 admitted to the intensive care unit? And again, almost 60% saying DVT prophylaxis, and another 55% prone positioning, and then steroids here saying 55%. Full anticoagulation is only in about 42%, and I wonder if this is mainly in those who are proven positive DVT or if they're in the ICU. I go to question number 9. Select the medication treatment that you are using or used and believe that make patient improve. And you see that prone positioning is one of the highest, followed by DVT prophylaxis. Then comes in all the other medication that we have mentioned. And last, number 10, please select the medication treatment that you are using or are using and believe that did not make patient improve. And here we see the antibiotic is one of the highest, followed by chloroquine. So kind of the opposite what when the epidemic first started, those were our first line of treatment, and it's interesting to see that. There's also convalescent plasma is also mentioned, but then again, it depends what resources you have. So we should always keep in mind these questions with regard to resource. But this is a quick summary. Will be interesting to see when we compare it to all the other 13 weeks we have done this, how these answers have changed, Dr. Marttos, but it's a quick summary.
Thank you, Dr. Aboutanos. I'm going to go straight to Dr. Lilian Abu. Dr. Abu, during one of her presentations, said the protocols are changing every 6 hours. So Dr. Abu, after 14 weeks, what did you learn? What kind of tell us what's really is in the past, should not be used anymore, or what you think is still need more research? So what kind of recommendation for protocol guidelines can you give to our friends in Latin America, Dr. Abu?
So the lessons learned is that, yes, at the beginning of the pandemic, things were very rapidly changing. It was extremely stressful. There was not enough time to read what was being published, and most of the information was coming from China, where they had a different test, different performance characteristics of the test. As we started to see the pandemic evolve to Europe and to the United States, and now in Latin America, we started to get different information. We have been able to test different hypotheses, and I think now we have a little more evidence-based practices. Still not perfect, and a lot of the things that you have seen have been published and then retracted from major medical journals, which is shameful. So again, it's a time of ethics and concerns where it's very difficult now to believe anything, because half of the information comes in WhatsApp and the other information comes in preprint, and then it comes in a journal, and now we don't know if it's true or not. So I would say it's still fluid, it's still changing. We know a lot more today than what we knew 14 days ago. We are not using lopinavir, we're not using Calitra, we are not using hydroxychloroquine. I think the data on hydroxychloroquine, it's still not perfect, but from our experience in critically ill, seriously ill, we did not see a major survival. There's still some controversy in people who had mild disease and were treated as outpatient. Did it really help or not? But now the FDA has withdrawn the emergency use of hydroxychloroquine. So even if you want to use it in the US right now, you can't. Unless the patient has some other immune conditions like lupus that you really need to use it. Then the other things that we're seeing is, I'm super happy to hear the presentation of Dr. Barrera. It's been really eye-opening to see how they have evolved through this pandemic. In Miami, we're seeing a different situation, and we don't have enough time to talk about it today, but I would warn everyone, don't get optimistic too soon. It's like climbing the top of Everest. You make it to the top, and then you're going down that slope too fast. You may still have, you may get in trouble and not survive the descent. So the same thing with the pandemic. We got over the top, we flattened the curve, and as cities reopened, we're seeing people getting too comfortable. We're seeing people coming to work, with a cold, and now we have transmission among healthcare workers. We're seeing visitors coming into the hospital, coughing and visiting their family member, and then 2 days later, the family member is positive for COVID. We were not seeing this during lockdown. So people are going to restaurants, they're socializing. I know everybody's stressed, but this is not over. And don't take your foot out of the pedal because cases are going up. We already saw a 20% increase in 2 weeks. And again, younger people, not as critically ill, but we don't know. We don't know what it's coming. We still don't have a vaccine. And we still don't have a single drug that we can say this is a miracle drug and cures the disease. So I think we still need to err on caution.
Thank you, Dr. Abo. Dr. Coimbra, so what's your vision about that? What's happening in California? Please give your advice to Latin America, please.
Well, I don't know if I'm in a position to give advice because, as you said, we were excited that we had stabilized the situation in California a couple weeks ago, or about three to 4 weeks ago. And then society starts to reopen, like Lillian said. And for the last 2 weeks, our numbers are climbing up again. And the governor of the state of California established a threshold of positivity rate of 8%. And if you go over, he may impose lockdown again. This is generating a huge political battle here. But it turns out that in our county, we were at 8% for several days. And in the last 3 days, we jumped to 12%. So we got a call yesterday and from the state saying, we are watching you. And today there is a call at 2 p.m. with the governor and HHS to see what they're going to do. It is very difficult to go back to a complete lockdown and shut down society and the economy again. So I guess the solution is to learn how to coexist. And I've been saying this every week here, how to coexist with this disease, being smart enough to contain it in a way that we don't spread throughout the community. But what Lillian said is very true. People just drop their guard. People just stop paying attention. It's incredible that this whole experience hasn't been horrible enough to teach people that we gotta act differently. The life is not gonna go back to what it was, or you're gonna get sick. And it's just amazing how human behavior is not affected by this, and our memory is so short. But again, our numbers are going up, and hopefully next week we can talk about strategies to reopen our hospitals, and yet have the ability to take care of COVID patients in the same facility. We are not going to go back to shutting down the hospitals and stopping elective surgery, but we need to be smart on how we do both effectively.
So I have a question for Dr. Barrera and any of the panelists. So it is interesting because we kind of have two separate, I should say, audiences basically here, or we have our Latin American colleagues and friends who, I mean, they're probably listening to us, but they're not even in that phase. They're in the search phase right now. They're into the how to contain this, and we are into, hey, how do we live in this endemic way with regard, like what Dr. Coimbra, for example, just mentioned. It's an endemic disease, where in land region, it's still in the pandemic aspect. So let me ask Dr. Barrera, what lessons would you give to our Latin American colleagues because we're learning a second lesson. How can they learn from the first lesson and not go into the second lesson that we're learning that Dr. Coimbra just mentioned, as far as how long can people remain stressed? How can you come out of something or conquer something and not let your guard down? I think Dr. Barrera was muted.
Okay, it's a very difficult issue because what we're seeing here also, as Dr. Abo said, the defense is less and less on everybody. You know, we started wearing N95s and an N94 masks when we were going into the COVID units with a shield and goggles. Now, a lot of the young residents maybe use an N94 or just a mask, and they think that because they're younger, they're immune and everything. So that's a problem. In the population at large, I live in New York City, people are not distancing anymore. They are not working. There have been 70 days like this. So everybody is now in the corners having coffee or having a beer and talking. So there has to be an equilibrium on what are we going to do to let the people work in different schedules and how we're going to contain. So I think the most important thing is to continue to wash our hands, wear the masks, and hopefully contain the second wave. In New York City, we have not seen a second wave yet with all the protests, the riots that we had in the last 2 weeks, and that's encouraging. So we have not, as I said, we have not admitted any patient in the last 24 hours with COVID, and we should, because Queens had a lot of protests.
Sure.
So that's number one. Hopefully we're beyond this. Now the other thing from the hospital perspective, as of today at noon, we can receive visitors.
Mm-hmm.
So that's going to be an interesting case to see how we're going to deal with these visitors. Do we take their temperature? They have to wear a mask. Are they going to wear a mask? How are they going to congregate? So this is another thing that we still have not elucidated how to implement this, the new visitors policy. It was great not having anybody except doctors and nurses, no administrators in the hospital. If there's any administrator, I apologize. But now there's going to be a lot more people in corridors, not social distancing. So that's another issue that we have to deal with. So I think education is the most important thing for everybody.
Great, thanks, Dr. Barrera. So Dr. Fognini, let me put it from your perspective, because you and I have been connecting in a different form with regard to what can the Latin American region learn from the rest of the world and what actually does not apply, you know, as you're going through this. And you mentioned right before this conference that you were in the thick of it.
Yeah, well, to use an old term, we are a third world country, and the United States is the first world. A lot of the things that have been discussed as far as equipment and PPE just does not apply to our region. We do not, we don't produce our own masks, and definitely not N95s. And we've had a lot of issues with counterfeit equipment. So I think that we have to be even more rational in the use of our equipment. I would love to be in the hospital every single day with an N95. The reality is that I reuse my N95. The reality is that when I do surgery, a lot of times we screen the patients. We do a CAT scan because RT-PCR is taking 4 to 7 days, and probably now it's about 10 to 14 days to get a result. So because the whole system is collapsed. So we have to rely on other measures. So we're scanning patients, and personally, I'm not going to the OR until the patient is intubated, and I leave before the patient is extubated. But we don't have enough PPEs to use them as freely as the colleagues in North America. Our advantage has been mentioned is that we are learning the lessons from the experience from Europe and from the United States, and that is allowing us to start implementing better care earlier during the course of the disease, and hopefully that will help us mitigate the fatalities in our institutions. But we are having significant issues with social distancing. Nobody's respecting the quarantine. In Bolivia, at least, police have gotten sick, and the military, so nobody's quarantining or controlling the streets. and we're almost getting to normal activities, and the numbers keep on rising, and there's no end in sight. So it's rather distressing. But I would say the difference is that it's the main thing is PPE, and that we've had the advantage to be able to learn from the experience from North America and from Europe.
Interesting to see how in West Africa, the military was actually effective in really imposing the quarantine, and now you kind of mentioned that it is the military itself, or the police are themselves getting sick, which becomes a big problem. And I quickly switch to give Dr. Salamea a question with regard to Ecuador. What are you at? What are you seeing from your end?
Thank you, and hello everyone. I think the problem in Ecuador was we have the first cases very early. We started the problem in February 14, and now all the population are very tired about quarantine. And the people need to leave the home, need to work, need money to eat, and it's very difficult to keep insulated. The situation now in Ecuador is very, very difficult. I don't know if we have the peak of the wave or we are in the second wave. I don't know. Or maybe I like the slide from Dr. Barrera, the 4 waves. Maybe now we are having the 4 waves because our deaths are very high, but really we have more deaths, but with the other problems, with the other problems with the patients, we have problems with ICU beds. Now all of the country are in troubles, and also the problems are the medical problems, the social problems, and the big problems in the mind of the population is the economic troubles.
Thank you. I have a quick comment here. So Dr. Coimbra said very well that this coronavirus, COVID-19, going to be endemic, going to be with us for a while. But what I think that what's happening is that once the population get tired, they see the curve is getting flat, etc. People had the feeling that it's over, but it's not really over. I saw here in Miami people going out with no masks or not doing social distancing anymore. And they're seeing what's happening here. And again, my hostel was going to start reopening for visitors this week. So now it's not reopening again because of the numbers are going up. So my question to Dr. Peralta, Dr. Peralta, do you think the people, they have the feeling or they understand that this is not over? Even okay, if you start to reopen, they have the feeling that they still need to continue doing the social distancing, using masks or washing their hands, or they're not getting it, it's just tired and they need to go out and they're not having the feeling that this is endemic. We're gonna need to deal with this. Our lives are gonna be changed for a long time.
Good. Just in a second, let me just echo what Esteban just mentioned. We have a great similarity with Bolivia from the Dominican Republic point of view, because we are the 2 countries that we have an election. Election is worse than the pandemic right now. Everybody's lying, everybody's modifying the number, and the campaign is all over. So it's no mask, it's 1,000 people, they give him free food, they give him free chicken and so forth. This is a disaster. So we know, we just had a note from Santiago, the 2nd city, that one of the major private hospitals is full. It's no, just have a public communicated. And the other hand, from Qatar and the other side of the world, we never closed for the construction site, never closed, because we really established epidemiological boundaries by establishing a tracing, and the tracing was manual, and tracing was using artificial intelligence, and also the phone and the virtual tracing that we call in the digital tracing called here is EtherAx. So when you go to the supermarket, when you go to the hospital, when you go to the bank, you cannot really enter unless you show your status and the EtherAx, so, and your tracing. And actually what we're seeing is the peak now is going down, but it's still People are tired. You know, we are 4 months in this thing. We started around, you know, January. People are tired to be here. And then, you know, the heat now is around 50 degrees here. So people wants to go out to the mall. The mall start opening now, but you know, the haircut, I haven't done one since February. Look at me, like that since February, so I still closed. But I tell you, they respect here. They have police. They have cameras that they know that if you don't have your Etherx, you don't have your mask, it's a mandatory outside the house to use mask. It's 10 times better than the Dominican Republic. I just can tell you that.
So I have a question that's maybe a little bit, I hope it doesn't offend anyone, but if you look at the normal, not the normal, some of the aspect that you see, especially you mentioned the political aspect, what the numbers are, can always trust the numbers, and corruption. Those are two things that Dr. Marchain actually mentioned in his presentation. The corruption, and now the use of the data for your own benefit, you know, and how do you compare that with regard to hospital-based data versus government data? And this has always been a big differences. I think this is where WHO had significant issues. So let me, I'm not sure if Dr. Marchain can answer that, or if Martha can answer that question.
Well, you know that a registry in, at least in the public system in Panama, is not the best as for the hospital-based registry. So the numbers are getting concentrated through the health minister. But if you see, the numbers are not equal, the ones that you have in the WHO and the ones that are reported in here. And I do not have an explanation for this. We are having a construction of a 100 bed hospital, new hospital to get people inside, and it has been so many scandals of corruptions, overpricing, getting the equipments. Actually, I think, I'm not sure if corruption is worse than COVID for Latin America, and the toll that we're paying for this probably is not gonna be evidentiated until, I don't know, maybe 1 year more, because of, there have been asking for some loans to the Banco Mundial, and huge amounts of millions of dollars, and you don't see the results, and people are not getting the results. And this is really frustrating, and that's making people not to follow the recommendations that the health experts are giving. So it's a very complex problem, and it's not only for health issues regarding only hospital-based or whatever. It's also economic and social problem, and it's horrible. At least in Panama, I can say. I don't know other countries. Don't want to talk back about other countries.
Mike, I just wanted to add a little bit. I think that this disease, apart from the medical aspect, and I appreciate that Gustavo mentioned it, there's a social aspect. I think this disease is highlighting the social inequities that exist in our countries. It's highlighting the lack of foresight from our governments. It's highlighting the lack of leadership across the world, and the failure of the politicians, who are politicians more than they are leaders or human beings. And the corruption is rampant. The corruption in Bolivia is rampant. They purchased 170 small vents, which were ambu bags basically, which cost $6,000 in Spain, in Barcelona, and the government was charged $30,000 for each item. So what would have cost $1 million cost $5 million. There's a lot of people selling rapid tests for antibodies. I've seen centers, medical centers, where people are being bussed in to take these tests, which are unreliable and unnecessary. And the people are being put at significant risk because they're just loading them into buses saying, come over here, we have cheap tests for $30, tell you if you have COVID or not. So it really highlights the bad stuff in our communities. And like I said during my talk, what I do appreciate though is a commitment of so many physicians and scientists who have come together as an international brotherhood to work together. So there's a silver lining behind this. But everything that's happening in the United States and is happening in Latin America right now is just highlighting social inequities and failures of the governments.
I think very well said. You know, it's interesting, and I'm sure Dr. Campbell will comment on this, is that we as the leaders in trauma have noticed very well. The social inequity is a disease that we deal with from the trauma aspect. And now dealing with the COVID and us being the leaders in disaster management on this, it's not something that strikes far from our understanding, but definitely called for us to answer to. And it's very difficult. And I think at the very beginning, maybe it was session 2 or 3, Dr. Campbell was actually highlighting the US involvement in this disease and the political part. It's not limited to Latin or to lower middle income countries. You know, it's very much human nature, as you mentioned, Esteban. Dr. Campbell, you want to comment?
Well, you know, this is obviously a complex issue. You're not going to solve it here today, but corruption aside, because corruption has always existed everywhere, particularly in Latin America, but corruption aside, I think that the most important lesson to me during this pandemic is the issue that Esteban mentioned of leadership. People watch TV. So if our leaders go to TV every night and give mixed messages or give the wrong message, it's just like our president here in the US. He goes to TV and promotes hydroxychloroquine and induces people believing that drinking a cup of bleach will clean them from the inside. You know, this stuff needs to stop. Why there was a difference between us in North and South America, in Latin America, and Asia, for instance? Because they had these problems before. Everyone wears a mask. We go to Asia for vacation and we think they are all crazy because they are wearing a mask, and we keep asking ourselves, why are these people wearing masks? Well, guess what? It works for them. The disease had very low numbers, very few people died. They had a much better performance than we had. And it's a simple thing. We just don't accept it. We need people, our leaders, to go to TV and stop giving wrong or mixed messages. Now, if you look at the United States, why Dr. Barrera was able to present the results that he presented today, why New York City was almost decimated by this disease and came out of it at the top, because they had positive leadership from their politicians. The governor of New York was an excellent leader that all the governors in the country should follow. And you know, they were systematic, and the hospital systems responded and the public responded. Now, we need to keep those messages going. What we can't do is to use the media to affect public opinion in the wrong way. So the issue of masking, washing hands, and social distance is really important. And that has nothing to do with corruption. Corruption will continue, and it's not going to be solved by this disease. It's always aggravated by this disease because people take opportunity. But really, leadership, you know, it's something that we should count on from those that represent us. And I think that's the biggest problem.
Very well said. Thank you. Dr. Marchain, últimas palabras de su parte en términos de qué hay que hacer de su parte de una manera para combatir ¿cómo se llama? Enfermedad.
Sí, Michael, evidentemente nadie tiene la receta mágica. En estos momentos todo el mundo está esperando que aparezca una vacuna, y mientras tanto tenemos que seguir luchando. Mi país tiene pocos casos y eso ayuda, pero también es importante lo que se hizo en el sentido de una cuarentena precoz, de aislamiento de las personas, el cierre de colegios, lugares públicos, y sobre todo la concientización, porque no es fácil, porque hay un problema social y económico que va parejo a todo esto. Actualmente hay un problema social y económico en el país que trae aparejado el hecho de estar en cuarentena por 2 o 3 o más meses. Pero en este momento esta es la receta que a nosotros nos ha dado resultados.
Una cosa que el doctor Coimbra acaba de decir, que la más importante cosa en este problema que tenemos es realmente el liderazgo. Liderazgo en cada país. Hay que tener liderazgo a diferentes niveles, como no solo a nivel de ¿cómo se dice? Social, pero político y todo eso. Parece que es la misma cosa que ustedes tienen en Paraguay, en toda parte del mundo.
Así mismo es, Michael, ¿verdad? Y quisiera agradecer una vez más la posibilidad de compartir este excelente panel.
Antonio.
Yeah, so we started this conference, this webinar 14 weeks ago. We have been asking ourselves for how long we're going to continue to this. I would say we're going to continue as long as we can still learn with each other. We still can help each other. As you know, we learned with Dr. Hayato and our friends from Europe. Now you had our experience in North America. Now Latin America is suffering. I just read some reports that Africa is having a 25% increase of case. I don't know. I hope Africa not going to have the first wave. Maybe just a delayed first wave. So you are still learning a lot with how to treat the disease, how to manage the disease, the new drugs, new treatments, and now we are facing second wave in the United States. So we're going to still continue because this is showing how strong the human being can be when they're together with the same goals, with the same objectives, and trying just to help each other. So I hope to see everybody next week safe when I'm going to be discussing the second wave and what's happening after reopening. Thank you, Dr. Aboutanos. Thank you, Dr. Coimbra. Thank you for all the panelists for being here once again. And I hope to see everybody next week. Gladys, Gary, Stephanie, Valeria, thank you for working in the background to make this conference happening for so long. Thank you, everybody. Stay safe.
Thank you.